which preoperative factors influence the surgical outcome of patients with non-flaccid facial paralysis who undergo selective neurectomy. Selective neurectomy was popularized in recent years and aims to improve the smile in patients with facial hypertonicity and synkinesis. During this procedure, distal facial nerve branches that generate unwanted movements are transected, favorably altering the vector forces on the medialis. A recent publication by Kaufman-Goldberg, Hadlock, and team assessed overall selective neurectomy outcome and examined the relationships between preoperative factors and selective neurectomy outcome using face survey, e-face, and Emotrix. In this retrospective study, 58 cases were performed. Looking at overall outcome, multiple e-face and Emotrix metrics demonstrated statistically significant improvements from preoperative to postoperative facial function. Around the eye, the resting palpebral fissure and ocular synkinesis improved significantly after the procedure. Looking at smile metrics, the average smile excursion improved by 2.7 millimeters, and the average lower lip asymmetry improved by 1.6 millimeters. The nasolabial fold depth at rest and some synkinesis metrics also improved significantly postoperatively. Importantly, no parameters showed postoperative decline in facial function. Overall quality of life was significantly improved after selective neurectomy. Looking at the effect of preoperative characteristics on selective neurectomy outcomes, several important correlations were found. Postoperatively, greater improvements were found in patients older than 50 years, patients with facial paralysis duration over 2 years, patients with poor preoperative facial function, and patients with non-trauma etiology. When examining the effect of age on outcome, older patients' improvement was higher than younger patients when assessing smile excursion, lower lip symmetry, ocular synkinesis, and static, dynamic, and total e-face scores. Looking at etiologies, patients with facial paralysis caused by trauma had significantly worse outcome in smile excursion, static, dynamic, and total e-face scores compared to patients with infectious etiologies like Bell's palsy, Ramsay-Hunt, etc. Facial paralysis duration analysis discovered that patients with long-standing paralysis of over 2 years had greater improvement in smile excursion. Lastly, patients who started with less favorable facial function demonstrated significantly higher improvements in several metrics, including eye, smile, and lower lip symmetry. In conclusion, selective neurectomy improves synkinesis around the eye and mouth with some differences based on age, cause, duration, and preoperative function. These data can be helpful to surgeons and patients in expectation management and patient selection.